Hello, I'm Ed Kilbane. One thing in the brief bio that wasn't covered, I've been board certified in public health and preventive medicine, and I had a slight career in public health too. So I kind of take an epidemiologic biostats approach to some of this. So I work for the National Disaster Medical System, and I'm sure today they're up in the operations center over at HHS preparing for the oncoming storm. When I go up there, I generally fill in for the chief medical officer, and typically a question that they ask me is how many people will die from this storm? I know your job is to figure out how many people died from a previous storm. I have to predict. So I generally let them know that I think one of the studies that was done by Enrique Mendez in Puerto Rico, kind of showed that people generally are pretty well prepared for the storm, but you do see a bump due to a variety of conditions afterwards in the recovery period. And then I tried to tell them, and I would encourage you to kind of take a look at your job, and I'm glad I'm on this side of the table and you're trying to solve this problem. What is the data that you're dealing with going to be used for? And when I'm involved in a response, it changes over the course of the response. Early in the response, we primarily want to know how many people are dead. And when I look at how many people should be dead, I'm looking at the mortality rate. And generally, when people ask me how many people are, how many deaths are expected, I go to the mortality rate. In general, it's about 22 per million per day, and I give them a quick calculation, and they're almost always horrified that people die every day. And last time I had to tell them, I came up with 81.5 deaths per day, and I thought the problem was going to be explaining that 0.5 death, and it wasn't. I mean, you would have thought I was picking people off with a sniper. They really had no appreciation for the fact. And early in a response, it doesn't matter to us as responders what the death is from. We have to provide for that. And and I predicted that the best way to figure out what the effect of the storm would be to look at excess mortality. And the idea is that if you're counting, it's a binary variable. Unfortunately, it's a lag indicator. I mean, because we aren't going to fix those deaths. But what we could use that information early on is to identify perhaps vulnerable populations, a particular problem, a particular location that may be used to modify our response. And no matter how many resources you have, you're always competing, you're always trying to craft your response to the appropriate circumstance. So, but as time goes on, you can refine that. You can get more and more information, and hopefully shape your response better. Since I do sit up in the operations center and serve as the chief medical officer, I think I can also comment on some of the morbidity aspects of what we do. We send out response teams, our disaster and medical assistance teams. Oftentimes, thousands of our personnel will go out to a response if it goes for a long time. And our personnel, we have an electronic medical record. And every day I would sit, especially if I was on the night shift, going through those medical records to look for trends. We have some people who actually do quite sophisticated statistics on them. We do have a statistical analysis branch in our operation. In general, they are primarily concerned with answering the questions of leadership they aren't really doing surveillance like a public health department would do. They're there to answer questions from our leadership. It's not that I get to see a random sample. I get the data that's fed into us. And also it's not like I get to see every record, because the electronic record is not very popular, and we wind up after every response with boxes and boxes of paper forms, which we can't, which is hidden knowledge. But we do get an idea of what's going on. And sometimes we do pick up gastrointestinal outbreaks, et cetera. Sometimes we do figure out a trend or a particular disease, but again, with both mortality and morbidity work, we're the federal government. We are not in charge. We're there to support, so we can report all of these things and perhaps help states craft requests for further assistance. But we generally don't have the power to intervene or do things on our own. So that's my initial, and I'm happy to discuss more with you as the hour goes on. Thank you.